Good day, everyone. My name is Christopher Alabi. I'm a second year internal medicine resident training at the East Florida JME program out of the West Side Regional Medical Center and the Northwest Medical Center, both in South Florida. My topic today is a case of microangiopathic hemolytic anemia secondary to metastatic small cell lung cancer. This case is that of a 62-year-old lady with a past medical history of hypertension and 30-pack year smoking who was brought to the emergency room with worsening generalized weakness of 1 month and associated unintentional weight loss of about 4 months with intermittent confusion. Physical examination revealed tachycardia and sparsely distributed purpura on all her limbs. Abnormal findings on initial labs include a hemoglobin of 6.9 grams per deciliter, platelets of 5,000 per microliter, elevated LDH, reduced haptoglobin, elevated liver enzymes, and a blood smear that revealed schistocytes. A full body imaging revealed a large mass in the right hilar region, also invading the right mediastinum, with associated lymphadenopathy. Innumerable liver masses were also seen, which were highly suspicious for metastatic disease, as well as a soft tissue mass underlying the skin in the right side of the abdomen. Extensive workup was undertaken, including Adams 13, and they returned negative. Treatment of thrombocytopenia began with plasmapheresis, and packed cell transfusions were given for the anemia. A biopsy of the abdominal soft tissue mass was obtained, and while results were pending, several courses of plasmapheresis treatments were given, but her platelets failed to improve. The results of the abdominal soft tissue biopsy was positive for poorly differentiated small cell lung carcinoma. The diagnosis of microangiopathic hemolytic anemia secondary to metastatic small cell cancer was made. Consequently, chemotherapy with etoposide and cisplatin was commenced, but on the third day of the first course, she declined further treatment and opted for discharge home with palliative care benefits. Sadly, she died 2 days afterwards. This slide reveals the images seen. First is that of the blood smear showing schistocytes, and then we have the chest X-ray, the chest CT, and also the CT of the abdomen, identifying the subcutaneous abdominal mass, which was biopsied. Discussion: cancer-related microangiopathic hemolytic anemia, coined CR-MAHA, presents a unique diagnostic and treatment challenge. In this case, the underlying cancer had not been diagnosed before her presentation, and the initial presentation of the patient with altered mental status, anemia, thrombocytopenia, and purpura was suggestive of thrombotic thrombocytopenic purpura, TTP. Now, TTP is a hematologic emergency which requires immediate treatment with plasma exchange. However, plasma exchange does not play a role in CR-MAHA because its pathophysiology is not related to antibodies to Adams 13. The proposed mechanism of CR-MAHA is microvascular dissemination of tumor cells, causing mechanical sharing of blood cells and platelet consumption, or as a result of bone marrow necrosis in hematologic malignancies. We believe the former to be the mechanism at work in our patient. Now, the 1 month mortality rate for CR-MAHA is about 50%. However, treatment of the cancer is associated with improved survival. We believe the advanced stage of the malignancy in this patient at the time of diagnosis was responsible for the unfavorable outcome. As a result, we could not remedy her condition even though we initiated cancer treatment for her. In conclusion, we recommend having an index of suspicion of cancer or metastasis when evaluating microangiopathic hemolytic anemia, and we hope this contributes to the body of literature as one of those rare cases where MAHA is seen secondary to small cell cancer.